Hi everyone, I'm Dr. Jim Harris. I'm excited to be here to talk about mast cell disorders and dysautonomia. I'd like to welcome you to the Awareness for POTS's conference today, and very excited to learn more about the condition myself. I am personally the medical director of the EDS clinic. We have multiple providers in over 20 states doing telehealth for EDS and other conditions. I personally saw over 1,000 trifecta patients last year. I am board certified in Allergy and Immunology, and in my career I've conducted over 300 clinical trials, including COVID vaccines and Xolair. I specialized in the trifecta, MCAS, mast cell activation syndrome, Ehlers-Danlos syndrome, and dysautonomia, especially POTS. I personally have no financial conflicts to disclose. So let's talk about mast cell disorders and dysautonomia. Let's talk about the prevalence. How common is it? What are the symptoms? How do you make the diagnosis? What is the treatment for mast cell disorders? And finally, what are the associated conditions that go along with mast cell disorders? First of all, mast cell disorders are a very common condition. It affects 15 to 20% of the population, and that is 80% female. It's 5 to 1 females to males, which doesn't seem fair, but that's the numbers. It affects nearly every system in the body. It's a relatively new diagnosis, just over 10 years old now, and the diagnosis is often delayed or missed. MCAS is a hidden giant among chronic diseases. When you look at hypertension at 27%, high cholesterol at 22%, MCAS ranks right behind that at only 17%. That's ahead of diabetes at 13%. Think about that. It is more common than diabetes. POTS at 3% seems fairly small, but yet when you look at the population prone to fainting, many of those may have POTS, and that is at 20%. So it may rank right behind diabetes and MCAS. So MCAS is a relatively new diagnosis, just over 10 years old. It was first described in 1988, possibly a cancer diagnosis at that time. It was said to be theoretically existing. Not until 20-some years later was it described with diagnostic criteria as consensus 1, giving defined criteria to make the diagnosis. Consensus 2 followed shortly behind, which had a different opinion. We'll talk about that. In 2016, MCAS was assigned a diagnostic code. In 2022, POTS got its own code, but well behind MCAS, believe it or not. In 2020, the Atlantic magazine described long COVID as having many symptoms that overlapped with MCAS, including fibromyalgia, dysautonomia, and mast cell syndrome. So a lot of similarities there. So how do you diagnose MCAS? Everyone agrees that you must have the symptoms consistent with mast cell activation. Those are symptoms in at least 2 organ systems. You've ruled out other diseases with similar symptoms, and finally symptoms that respond to treatment. There's consensus 1 and consensus 2. Consensus 1 is the group that says lab documentation is required. You must have an elevated tryptase level, response to an episode or attack, also with clinical symptoms. Consensus 2 says clinical symptoms are required, but lab documentation is only supportive. You don't need the numbers to make the diagnosis. So why is mast cell activation syndrome so underdiagnosed, delayed, or missed? It's not taught well in medical school. It's a relatively new diagnosis, so many people never heard about it in medical school or otherwise. There are very few specialists who really treat or identify mast cell activation syndrome as a problem they treat. Allergists are the most likely group, but even they are not likely to be able to diagnose it correctly often. It's a complicated multi-system condition. Site conditions are common, so many people are diagnosed with that first before they get the diagnosis of mast cell disorder. Patients look normal. All the tests are normal. So it often takes more than 10 years to make the diagnosis because of all these overlying conditions. All that is to say that most providers are frankly dazed and confused. To quote one of my favorite rock groups in history, Led Zeppelin, Dazed and confused is pretty much describes the field. So what about long COVID? 30% of U.S. adults develop long COVID after COVID infection. And how do you define that? Duration of symptoms, 3 months or longer. One or more symptoms that are similar to MCAS, especially fatigue, and one or more diagnosable overlapping conditions. There overlaps with MCAS, POTS, dysautonomia, or fibromyalgia. So are they the same condition, just made worse by the COVID? Who knows? We have yet to define that. But it does not require lab confirmation or proof of the initial infection, oddly enough, to diagnose long COVID, and very, very common condition. So MCAS is one of 3 diseases in the trifecta: MCAS, POTS, and EDS. We've been talking about MCAS, variable condition, often unpredictable, allergy-like symptoms, many symptoms like irritable bowel, food intolerance, migraines, flushing, itching, fatigue. Affects maybe 20% of the people we've talked about. POTS may be only 2%, but overlaps with MCAS because many of the MCAS patients have rapid heartbeat, palpitations, fainting, dizziness, and worse with exertion. Ehlers-Danlos is strictly a hypermobility condition, but yet many of the same conditions exist with EDS patients. We say it's 1 in 500, but probably a lot more common than that, maybe even as often, or as common as 1 in 200. And there's no genetic marker in 99% of those patients. No test that proves it. So what are the symptoms of MCAS? It takes a positive history for 2 out of 10 conditions in the review of systems. Fatigue is the most common symptom overall, but psychological issues like anxiety and depression are common. Neurological problems like migraines. The most obvious symptom is skin problems like flushing, hives, heat and alcohol intolerance. Most of these patients cannot tolerate heat. They can't take a hot shower. They have to turn it down to a cooler temperature, sit down. They finish the shower. They have to recover for half an hour to an hour. That's the easiest thing to tell from a history. But they also have nasal allergies, asthma, cardiovascular problems like POTS, GI problems, irritable bowel, cramping, bloating, constipation, diarrhea, bladder issues, and bone and joint issues, just like the EDS patients. This slide shows the extent of involvement of MCAS. It involves virtually every system in the body. But if you look at the symptoms in the orange boxes, GI, gastrointestinal, neurological, and cardiovascular, those are the ones that really overlap with POTS. And so you can see how closely related these conditions can be. So what are mast cells anyway? They're the cells that protect us from invaders, infections, everything else that attacks the body. They're immune cells. They're present throughout the entire body. They play a role in the allergic and inflammatory response to a variety of conditions. They contain a small stacks of mediators that help protect us against those things. What are those mediators? Histamine is the main one we know about. That's the one we think about mostly, and that's what causes most of the symptoms, but also includes leukotrienes, prostaglandins, tryptase, interleukins, and heparin, which makes us bleed more easily and bruise more easily. So what triggers the mast cell? There are many things that trigger mast cell activation. Allergens, medications, odors, venom, diet, infections, temperature, stress. What's important about this is to identify the triggers so you can eliminate those or avoid them altogether. So when you look at the entire scope of mast cell activation disorders, over 90% are mast cell activation syndrome, meaning that most are idiopathic, the most common, especially with trifecta symptoms otherwise. There's no identifiable cause. Some have more uncommon forms, a monoclonal form that have a DNA variation or a DNA mutation. Some are secondary to other causes, but the great majority are idiopathic, have no specific cause. The more rare forms, mastocytosis, and those. In my career, I've only identified 1 or 2 in all the patients that I've seen, so they're really quite rare. My guess is mast cell activation syndrome is probably more like 95 to 98% of the total. So based on lab tests, how do you diagnose MCAS or mast cell activation syndrome? First of all, tryptase is the cardinal test that we use for mast cell disorders. If you look at the consensus 1 versus consensus 2, there's a big difference in that level. First of all, the consensus 1 group would say that you have to show an increase in baseline tryptase level of 20% plus 2. Consensus 2, of which I ascribe to, the increase is important, but it's not needed to confirm the diagnosis. In any case, we all agree that anything below 8 requires no further workup for tryptase. If it's above 8, then further testing for more severe forms is necessary. If it's above 20, you're more likely to have a systemic problem that really needs a very aggressive workup. So what does the workup entail? More severe forms, you look at genetic testing. That would be, first of all, hereditary alpha tryptosemia test, HAT or HAT test. That tends to be associated with not just anaphylaxis, but also tends to elevate the tryptase level. And so we need to use that as a tool to figure out what is the true tryptase level. But more research is needed for that condition. Secondly, DNA testing for KIT D816V, which is a monoclonal DNA mutation, tends to be associated with more severe disease and leads us on to then a more aggressive workup as well. And finally, with very high levels, we need to have a bone marrow biopsy to see if the bone marrow is involved, which may or may not be the case, but that's where you go with this kind of level. Finally, there are additional markers that can be checked, especially urine tests. 24-hour urine tests can measure histamine, prostaglandins, and leukotrienes. It provides additional clinical information about what may be the mediators involved, but they're difficult tests to do. They often tend to be unreliable, so many of us don't do those tests unless there's a strong clinical indication that we're not controlling the problem. Additionally, it's important to test for comorbidities in mast cell activation syndrome. Many of these patients have deficiencies in a variety of areas. Metabolic deficiencies can be a major issue. Vitamin D, if deficient, can affect gut function, a variety of other conditions. B12, folate, iron, magnesium, all can be low and need to be checked initially and at least annually. A general workup is important, looking at CBC for anemia, CMP looking at liver and kidney function tests, TSH for thyroid function, SED-rate and CRP for inflammation, and finally, an autoimmune workup needs to be done because 20% of these people have an autoimmune condition. That can include lupus, Sjogren's, celiac, or Hashimoto's related to thyroid antibodies. So this is really an important point of this talk, and maybe the most important point, and that is without MCAS treatment, POTS may be hard to control. Let me put it a different way. You need to treat the MCAS problem first because the POTS may improve with just that alone, but without going to beta blockers and all the other things you do for treating them. Very important to identify and treat MCAS along with the POTS. So the treatment of MCAS really focuses on the mediators released by the mast cell. First of all, histamine is the main mediator released, so antihistamines are the cardinal therapy for MCAS. The H1 blockers like Claritin and Allegra, Zyrtec, H2 blockers like famotidine, which you think of for heartburn, but also H2 receptors are found throughout the body. Blocking leukotrienes as well with montelukast and zafirlukast. Singulair is the one you probably know. Mast cell stabilizers for the gut like Cromolyn can block the entire mast cell reactions. They can make a big difference, sometimes hard to get, but incredibly important for many people with GI problems. Systemic steroids like prednisone and Medrol can block all the reactions overall. EpiPens are important for acute reactions that occur like anaphylaxis. And Xolair can be an important blocker as well when the other drugs fail to treat the problem effectively. With MCAS, once you've treated the basic MCAS problem, if there remain problems in addition to that in various systems, you need to treat them specifically. GI problems like heartburn, nausea, cramping, and bloating may need specific treatments in addition to treatment for the mast cells. Headaches, especially migraines, may need special medication. Pain is often not controlled with just antihistamines, so different drugs like NSAIDs and even gabapentin and Lyrica may be needed. Psychiatry, most of these patients have mental health issues, which may be better with antihistamine therapy, treating the mast cells, but yet may need additional treatment or counseling. Sleep is a problem in almost all these patients. They need supplements, medication to control it, CPAP, they have apnea, they have arousal problems, and so they need to be addressed. And finally, cardiac problems, the POTS issue that we all know and love. Tachycardia, low blood pressure may require a referral to a cardiologist. With MCAS, diet is critical. Supplements may help. Diet changes often have dramatic improvements in their problems. Eliminating dairy and gluten may be the biggest thing, but special diets that go beyond that, like low FODMAP, keto, paleo, and some things like that reduce or eliminate carbs, may make a huge difference in our symptoms. You absolutely need to rule out celiac disease and other food allergies and deficiencies that may occur with these conditions. Supplements are important. Most of them need multivitamins. They need vitamin C to help reduce or break down histamine. Probiotics can help with GI function as well. Testing may show a deficiency in vitamin D, B12, magnesium. Those may need to be supplemented. Other drugs that may be helpful, quercetin, may help with mast cell stabilization. Diamine oxidase may help break down histamine, and so on. A variety of other supplements that may be of value. Referrals are important, but it's often hard to find specialists who really understand the condition of EDS, mast cell, and POTS. So for cardiology, if we can't treat them effectively with the things that we try, it may be important to send to them to confirm the diagnosis, treat them, perhaps do tilt table testing for dysautonomia. For GI patients, when they have uncontrollable symptoms, gastroparesis seems to be the biggest reason we refer people. For neurology, they may need a sleep study. They may have a peripheral neuropathy that may overlap with other conditions like Parkinson's. Pain management may not be responsive to the things we try as frontline therapy. You may need more specialized care. And finally, if they have a markedly elevated tryptase, like over 20, positive HAT test, they may need hem-onc for evaluation. So when you think about POTS, dysautonomia, I think we're just beginning to find out what we need to know about these conditions. And those are, it's a big world out there. We're just beginning to see what's out there and how to treat these things and effectively diagnose them and treat them. So what I tell residents and students when I have them in my office is you need to look at the patient. They look normal, but you need to look at what their condition is. How do they feel? How do they move? Are they hypermobile? Listen to their story, because most providers have not done a very good job of that. You need to learn from them, because I learn every day from my patients, and they teach me things that I never knew before because I'm paying attention to their symptoms. Now, finally, I'd like to thank you all for the opportunity to be here. This is my favorite rock group of all time, the Beatles. I'd like to use some of their songs to paraphrase some of my comments here at the end. I'd like to say that I appreciate those who helped bring this conference here and help them come together for this meeting. It's been a long and winding road to raise awareness of POTS, dysautonomia, and other conditions like EDS and mast cell disorders. But we can always hope that the challenges of yesterday will become a reality tomorrow. When will that happen? We can only imagine. But something tells me we'll eventually get there. Thanks again for your time, and best of luck, and enjoy the conference.